Good evening, everybody. I, Dr. Avni Skandar, invite you on behalf of IRIA Preventive Radiology to this wonderfully unique webinar series where IRIA Preventive Radiology team joins hands with IRIA Kerala, Swasthi Foundation and Community Oncology Department at RCC Trivandrum. We join hands together to raise an awareness pan various societies, institutes, and pan public towards preventive oncology. Prevention is better than cure. Breast cancer incidence is on the rise, with it being one of the leading cancers in Kerala today. We all are well aware of the various screening methodologies available and the risk factors to be borne in mind. Then why wait for the disaster to happen when it's in our control to prevent and stall the process in most instances by merely being aware, reducing the risk factors, lifestyle modifications, screening, and follow-up. Some small modifications and alterations can help us in prevention or early detection of cancer and downstaging the malignancy and improving the quality of our life. With such a forward thought and a defined aim in mind, these groups are joining hands towards cancer. Under the able vision of Dr. JournoMed, National Coordinator Preventive Radiology and Secretary of Kerala IRIA, the other pioneers to this project are Dr. Gomati Subramaniam, President of Kerala IRIA, Mr. M.G. Srikumar, Swasthi Foundation President, Mr. Abhi George, Swasthi Foundation Secretary, Dr. Jay Krishnan, Associate Professor, Department of Community Oncology, RCC Trivandrum. I welcome each of these pioneers for the session. I welcome our chief guest of the day, Mr. Hemachandran Sir, IPS, former DGP, Advisory Board Member, Swasthi Foundation, and the speaker of the day, Dr. Kalavati MC, Additional Professor, Division of Community Oncology, RCC Trivandrum. I would also like to invite the panelist of today, Dr. Bipin Gopal Sir, Nodal Officer of Non-Communicable Diseases, Kerala State Health Services, and Dr. Tina Sliba, Senior Consultant Radiologist at Rajagiri Hospital. And of course, I welcome each one of you in the audience who promotes such a forward thinking. Now, to start off this session, I would like to welcome our President of Kerala IRIA, Dr. Gomati Subramaniam, ma'am, to deliver the presidential address.
Unmute, ma'am, unmute.
Good evening, all of you. I'm very happy that Kerala IRIA, under the enthusiastic leadership of Dr. JournoMed, we are conducting the preventive radiology sessions. We had a lot of sessions on preventive radiology, online and offline. I'm very happy that we are conducting a lot of programs from January onwards. And we had a World Cancer Day. We had academic sessions online for the public to give public awareness. And many of them appreciated the talk given by us on the World Cancer Day. And it is still being in the reception counter in the TV projected, because people are very happy to hear that. So as a part of preventive radiology, I'm very happy that we are conducting this program under Kerala IRIA. And we have a lot of good faculties like the Swasthi Foundation, the RCC group, the Malabar Cancer Group. There's a Pi Cancer Center in Malabar, where all of them are giving a lot of awareness this month, as this month is a cancer awareness month for the breast cancer. And we're very happy. We also conducted awareness in many of the institutions, started from October 1st, and we are conducting academic sessions also for the cancer awareness. I'm very happy to see a lot of faculties today who are going to have a panel discussion on the cancer and preventive radiology. I'm happy to see all the wonderful faculties who are going to speak today. So thank you so much for this opportunity. Thank you so much.
Thank you so much, ma'am. Next, I would like to welcome our chief guest of the day, Mr. Hemachandran Sir, IPS, former DGP, Advisory Board Member, Swasthi Foundation, to kindly inaugurate the function. Sir.
Good evening, all of you. When I got the invitation from JournoMed, Dr. JournoMed over phone, I was in Tellicherry. I had gone there to attend the funeral of Mr. Kodiyeri Balakrishnan, the former Home Minister of Kerala, with whom I had closely associated. He was a person who lost his life to cancer. But I would like to perceive him as a fighter who extended his life by 3 precious years as a result of the approach he took to dealing with cancer. After all, 3 years in human life is not a short period. It's something which is very, very valuable. And 3 years of productive life for a person who was in such a responsible position is something beneficial to the society. I think this is how we should look at the way we deal with the problem of cancer. I recall when Dr. Raji Matthew referred about the Trivandrum conference, I had an occasion to speak there. I referred to the experience of Dr. Amartya Sen, the well-known economist, Nobel laureate, who at the age of 18 in the early 1950s, he himself found some problem in his mouth. And when he went to a doctor in those times, in the early 1950s, when doctors were ignorant of cancer, it was very difficult for him to get it detected. In fact, the cancer hospital in Calcutta was just established. But because of his persistence and good sense by some good doctors at that point of time, he could come out of oral cancer. The life expectancy given to him at that point of time was only 5 years. But today he is still alive, 89 years old. Now I think he is fighting prostate cancer. See, but the important thing is, though we have come a long way in dealing with cancer, the medical science has expanded significantly. All of you are very competent doctors. And even in Kerala, we have excellent facilities, starting with RCC in Trivandrum. But I think there's a gap in reaching these facilities to the people. And that gap is not entirely because of absence of doctors or medical facilities or anything. I think one problem there is the lack of awareness, and also what I would like to call as lack of scientific temper. Amartya Sen, when he describes his incident in his autobiography, A Home in the World, in fact, I would suggest all of you should read his narration. He explains, he says, he refers to the ancient Indian philosophy of the Charvakas. He says for every physical event, there has to be a physical explanation. You can't go to spiritual things. If there is a growth in my hand or some swelling in my mouth or something, it must have a physical cause. That's he relates it to the ancient Indian philosophy. But unfortunately today, though the science has expanded, scientific knowledge and the way we treat the disease has expanded a lot. Quite a lot of superstition, unscientific beliefs, wrong notions are prevalent in this society, which is coming in the way of this. Even among the doctors, I would just mention one of my own personal incident involving my wife. 9 years back, I was at that point of time Additional Director of Police in Trivandrum. We were battling some major issues, law and order issues at that point of time, some secretariat siege and things like that, in connection with that so-called solar agitation. Some of you may remember. At that point of time, I was battling a personal battle at home. My wife was detected with some kind of abnormality in the mouth. We went to an elderly person, a family doctor. He said that it could be some, can be dealt with some antibiotics, and he prescribed for a few days. Nothing significantly happened. Then by accidentally, we went to another doctor, Dr. Ravindran, who was vice principal of Medical College at Trivandrum. a very senior doctor. He is not an oncologist. He was a pulmonologist. We went to him because at that point of time, he was ill due to some minor procedure was done. When we went to him, casually it was mentioned that my wife has got this problem. It was not bothering in a big way. But then he felt it that from that bed where he was convalescing, he contacted the radiology section. I could, because I know him for a long period, I could make out that he sensed something which should not be ignored. Then the radiology people intervened. In fact, the imaging procedures, all those things followed. Then what is called FNAC, which all of you are doing, it was done. It was diagnosed as pleomorphic adenoma. Then with it, that surgery is a little tricky. All of you know, because facial nerve and things like that is involved. So while outside all these things were raging, I was worried about this, and that surgery was done within 10 days. Within 10 days, because it can become malignant. That's what people say. The point I wish to drive home is, but for the intervention of a sensible doctor who gave good counseling, good advice and intervention, maybe this would have prolonged. And I know many instances where precious lives could have been saved, but for the failure of people, even educated people, educated in science, technology, engineers, doctors, who because of lack of what I would call lack of scientific temper, that is, if you have a problem, it has to be found out what is the cause, and a solution may be existing, and it has to be dealt with in the manner in which Mr. Kodiri Balakrishnan did, which helped him to extend his life by 3 years. But unfortunately, quite a lot of superstitious beliefs. People go after some magical bark of a tree, some tribal medicine somewhere. I am not against conventional medicine, but we should understand the limitation and the advantages of modern medicine. So my appeal to all of you in this IRIA and the people in the field of oncology, which a great job which you are doing in the hospital, I would advocate that you should also use your knowledge to propagate, to create awareness among the people, because that will save many lives, many lives. Kerala, in terms of physical quality of life, in terms of expanding our lifespan and things like that, have come a long way. Now where time has come, we are dealt with many massive spread of diseases, communicative diseases, and all in a big way, vaccination programs and things like that. But I think now a time has come, we should pay much more attention to dealing with the diseases like cancer. And that's where this kind of programs, educating people, creating awareness, and the importance of early detection, prevention, all those things come into play. I am very happy that now people like you are playing a very important role. Maybe you can save much more precious lives by communicating the right kind of communication to people. In fact, in Kerala, I have seen often it is the educated people who are ignorant about, who are negligent of all these kind of things. The common man with very little education but abundant common sense, they approach the problem much more sensibly. So this campaign which you have started, the IRIA has started in association with other groups, this should be strengthened and this should be carried forward, and that can save precious lives, and that will add value to the service which all of you are rendering to the society. And that's my fervent hope. And this movement should succeed in Kerala for the benefit of the society, and that's my hope. And with that hope, I inaugurate this program of the day, and with best wishes for all your initiatives ahead, I remain. Thank you.
Thank you so much, sir, for the wonderful narrative and for stressing on the importance of the appropriate investigation and intervention that is required. Exactly like you said, it should reach the public, it should reach everybody. That is exactly the motto that the Kerala Cancer Crusade is hoping to achieve, that we can reach more of the public, more of the people, and pass this message on. So thank you so much, sir, and thank you so much for inaugurating the function. Now, I request Dr. Jayakrishnan, sir, Associate Professor, Department of Community Oncology, RCC Trivandrum, to kindly invite the speaker of the day, Dr. Kalavati, ma'am.
Good evening, everyone. Good evening, Hemant sir, Dr. Rijo, Dr. Tina, Dr. Avni, Dr. Bibin Kopar, Dr. Kalavati. So my duty first is to introduce Dr. Kalavati. She's an associate professor in the Division of Community Oncology in Regional Cancer Trivandrum. And for more than 2 decades, she has been actively involved in cancer prevention control activities. And I think she is the one who had pioneered in taking cancer control programs to the doorstep of rural Kerala. That's what I can say. And she has, great experience or vast experience in cancer screening programs and also in cancer awareness programs and various training programs. And she has been actively involved in various women empowerment programs for cancer prevention control, especially the Kudumbashree Workers program in Pathanamthitta district and also the Trivandrum Corporation program. So I think her experience in controlling or in terms of what are her thoughts on early detection of breast cancer and on cancer prevention will be of good help to all the participants. And with these few words, I welcome Dr. Kalavati ma'am to this program. Over to you.
Kalavati, ma'am.
Good afternoon.
Good evening, ma'am. We can hear you, ma'am. Please continue.
Yeah. Good evening. Hello.
Ma'am, please share the PPT.
Yeah. Good evening. First of all, I would like to extend my thanks to Dr. Rijo Matthew and my own colleague, Dr. Jayakrishnan, for inviting me to give such a talk. And it is very happy. I'm very happy to be with you, especially the group of imagiologists who are actively helping me in my profession of early detection. Now we will start with the pink ribbon. Next slide, please. We know the importance of our the hands and early detection of breast cancers. This is a pictorial representation of that. Next. I'm Dr. Kalavati. I'm Associate Professor in the Division of Community Oncology, RCC. And I was involved in so many cancer control and cancer detection programs. And now myself, Dr. Jayakrishnan, we are involved in so many programs, as Dr. Jayakrishnan has rightly pointed out. Next slide, please. Coming to the burden of the disease, all these things you all know. Sorry for the repetition. The incidence of breast cancer is about 55 per 100 women, according to our own population-based cancer registry reports. So the prevalence must be around 150. But in the case of breast cancer, I suppose it will be much more higher because of the because curative rate in breast cancer is very high. And about more than 10,000 new female breast cancer cases are reported in Kerala annually, new cases. So the number of prevalent cases, I presume that you know the difference between incidence and prevalence. Incidence is number of new cases detected over a period of 1 year. Prevalence is number of cases living with breast cancer at a point of time. So the number of women living with breast cancer may be more than 50,000 in Kerala, and the incidence of breast cancer is comparatively high in Kerala, that of our neighboring states and other states. Next slide, please. Coming to the prevention, if we have to prevent a particular disease, if there is a single important risk factor for that disease, it's very easy to prevent that disease, as what is happening in the case of COVID. But in the case of, and also in the case of lung cancer, smoking is an important risk factor. So if you don't smoke, your risk of getting lung cancer is very low. But in the case of breast cancer, which is a multifactorial disease, there is no proven single important risk factor. So the primary prevention is very difficult. Next slide, please. So just have a look into the risk factors, which all of you know. I'm just reading it out. Aging, multiparity, late age of first marriage, no breastfeeding, early menarche, late menopause, BRCA1 and 2 mutation in the family, first degree, second degree relatives with breast cancer, postmenopausal obesity, surgery in breast for benign diseases, some benign conditions of the breast. Can I have the next slide, please? Then, so this is a very huge public health issue. This is a very important problem. Many women are living with disease. Burden of disease is very high, but you can't easily prevent this disease. Then how to tackle the situation? We know that survival for early stage detected breast cancers are 5-year survival. Usually we speak about 5-year survival for cancers. It is very good. In the case of stage 1 and stage 1 diseases, it is near 80%. And in stage 2 also it is good. But when it comes to stage 3 and especially stage 4 diseases, the survival rate is very bad. Sometimes somewhere between 30%, 5-year survival rate. That shows the importance of early detection. So here lies the importance. The easiest way to tackle the burden of breast cancer is to detect that cancer early. Next slide, please. How to detect it early? All of you know this. Self-breast examination, BSc, breast self-examination, clinician breast examination, breast ultrasonogram, breast mammogram, fine needle aspiration cytology, then in some cases, MRI. Next slide. Which methodology is cost-effective for screening? Coming to BSc, breast self-examination, it is simple, no cost involved, but effectiveness, number of false positivity is high and leading to more investigation load. And in the case of physician breast examination, again, access is the problem. In many situations, in many hospitals, lady doctors are not there. And if at all any lady doctor is there, there might be no privacy for examining a woman's breast. So all these problems are there. Many times it is leading to further investigation, but that is a good thing in one way. The next thing is ultrasonogram, comparatively cheaper, but many times again access. And in the case of mammogram, many times asymptomatic women are hesitant to do such an expensive procedure, investigation route as a routine. It is more expensive. But even then, it is considered as the gold standard for breast cancer screening. Coming to MRI, MRI is not routinely done as part of breast cancer screening and in specific conditions. It is very expensive also. And coming to genetic studies, BRCA1 and BRCA2 mutation studies can be done, but usually it's not being done for population screening due to so many issues, so many other social and cultural issues. And coming to fine needle aspiration cytology, it is effective in easily palpable lumps. It is very easy. But if the lumps are not easily palpable, then again we have to resort to ultrasound guided FNAC. Again, access is a problem, expense is a problem, and good laboratory services are also needed. Next slide, please. Okay, then let us talk about the risk stratification. Screening all women in the age group 30 to 65 in Kerala or in India, it's not feasible due to limited infrastructure available. So, risk stratification of women and offering screening and investigative services to the high risk category is the accepted strategy in breast cancer screening in countries with limited resources like India. We all know that in countries like US and UK, etc., all the women are given yearly annual mammographic screening, and they have their own schedule, and that will be intimated to them, and they have to go for mammogram on that particular day, every woman. I think above 40. But in India, we don't have that practice. And even in Kerala, which is supposed to be very, I mean, people are very educated, highly educated, health conscious, etc. You can't expect a normal woman, asymptomatic woman who is having a very good breast health. She is not having any symptoms, any pain or lump or anything. You can't expect that lady to go for a routine mammographic scanning on her own. Okay. So here, what we have to do is we have to categorize the people into high risk category and low risk average category. So that should be the accepted norm. The nulliparous women who had their first childbirth at a later age, women with BRCA1 BRCA2 mutation, women with family history of breast cancer in the first degree and second degree relatives, women who have undergone surgery for benign breast diseases, and women with certain benign breast conditions. All these are non-modifiable risk factors. They can't modify by, they can't be modified by the woman. Non-modifiable risk factors. These women with these risk factors can be included in the high risk category. Obesity, smoking, drinking, being sedentary, etc. also have a risk enhancing effect. These are modifiable risk factors. Obesity, obese women, obesity, that word itself, that includes so many factors. Being obese is related to so many other factors, maybe related to the fact that you are sedentary, maybe related to the fact that you are taking your fat intake is much higher, maybe it may be related to your thyroid issue. So many issues are there. So it is a lifestyle related factor. So obesity, especially post-menopausal obesity, is a risk factor. So that is a modifiable risk factor. You can avoid your obesity to a great extent in many cases, unless and until you have some other medical conditions. Then smoking, drinking, that for the time being, we are not much bothered about these factors in Kerala or in India, because women smoking and drinking are considerably very low. Next slide, please. All women who do not have the above mentioned factors fall under average risk category. We don't say low risk category, we always say average risk category, because all women are having average risk for developing breast cancer. Okay, so women who don't have the above mentioned factors, they fall under average risk category. Various tools are available to calculate the risk for developing breast cancer based on selected risk factors. We will be collecting data about certain risk factors from the women, and there are various tools can be developed to calculate the risk of that woman developing breast cancer in future. So in any screening program, focus on women with the above mentioned risk factors And women currently having any swelling or lump in the breast also can be included in the high risk category. Next slide, please. Methodology accepted is women with average risk, if attending the screening program, can be palpated, and if any breast lump is detected, can be subjected for imageological testing with USG for younger women with dense breast tissue, and mammogram for elderly women with less dense breast tissue. And it may be followed by FNAC, because in ultrasound or mammogram we are getting the clear picture, then FNAC can be done easily. I mean FNAC, I'm not talking about guided FNAC, but in lumps which are not easily palpable, many times guided FNAC might be needed. If the woman is in the high risk group, if the woman falls under the high risk group, if lump is palpable, can definitely be subjected for USG, mammogram, or FNAC. But even in the absence of any palpable lump, since the woman is under high risk group, women may be subjected for routine imageology according to the by taking into account all the other factors. And MRI may be reserved for women with no palpable lump in the breast but have strong family history. I have seen so many women. They have even 2 days back, one person came to RCC for breast screening as part of the October breast screening month program. Her mother, her maternal grandmother, and her great maternal grandmother, all these 3 people are suffering from breast cancer, and that too at an early age. So in that case, I have asked her to go do mammogram. But in some cases, if they don't have any palpable lump in the mammogram, usually sometimes we may have to ask them to undergo MRI screening. And people here are imageology people. They might be in a position to explain more about it. And history of ovarian cancer in the family is also a risk factor. But history of ovarian cancer, getting a history of ovarian cancer in the family is many times very confusing, because common people confuse it with cervical cancer usually. So that is an issue. But his history of ovarian cancer is also important. Can I have the next slide, please? And preventive, here I think it is a common pool of preventive oncologists, imageologists, and if I understand correctly, pathologists also. This forms an important trio in breast cancer early detection. All of you know that. The imageology results help in getting a diagnosis of cancer, precancer, ductal carcinoma in situ, etc., and sometimes equivocal, like Birat's 4A, 4B, etc., then benign or normal. In equivocal cases, FNAC may be of great help in many cases. In others, again, depending on the background risk, etc., MRI or follow-up or surgical consultation for biopsy, etc., may have to be done. And FNAC and biopsy act as factors helping in confirming the diagnosis. Can I have the next slide, please? Coming to the prevention of breast cancer. Many times there are, in the case of breast cancer, there are modifiable, non-modifiable risk factors and modifiable risk factors. Non-modifiable risk factors are your family history, the fact that you are the fact that my mother is having breast cancer, I can't do anything about it. So that is a non-modifiable risk factors. The fact that my family is running BRCA1, BRCA2 mutation, I can't do anything about it. And the fact that I had my okay, in certain reproductive factors, we have a hand and we can modify those things to a certain limit, like age of first marriage or age of first delivery, etc. in some cases. And So there are so many non-modifiable risk factors, but there are some modifiable risk factors also, like physical activity, your diet, and but your lifestyle, otherwise lifestyle. That is, if I want to do regular physical activity, that is my own decision. I can do it, or I can't. I won't do it. That is a modifiable thing. And the fact that what I have to eat, I am deciding. Okay, if I want to eat more vegetables, more fruits, and low calorie diet, that I can do. If I am doing it, okay. If that is my decision, that is a modifiable risk factor. Try to avoid being obese. The obesity is a result of sedentary life, your dietary habits, your other lifestyle factors, etc. So try to avoid obesity at any point of time, especially in the postmenopausal age group. And walk regularly as your health permits, even if you have an own vehicle. If I say this is the main reason for Kerala for people becoming obese, both male and female. All the people, both males and females, they have their own vehicle. At least two-wheelers, everybody have. So in Kerala, people are very hesitant to walk. So please try to come out of that. Work regularly. This is applicable to doctors also. I always say in my talk like this, I always advise my doctors friends also. Women with high risk may also concentrate on all these factors, but they should do regular self-breast examination, clinician breast examination, ultrasonogram or mammogram as advised by the physician, etc., which all help in detecting a cancer early. Because women without any high risk factors can practice all these things, and women with high risk factors also have to practice all these things. Next slide, please. Finally, come to some facts. Having risk factors do not mean that you will develop breast cancer. That is there is a cancerophobia. For many women are suffering from cancerophobia. I know that because many come to our OPD with the fear of getting cancer. They come frequently. So try to understand that even though we have risk factors, that doesn't mean that you will develop a breast cancer. Many women develop breast cancer with no identifiable risk factors. And but women with a high risk factor profile have a slightly higher risk for developing breast cancer. We have to understand that. That doesn't mean that you will develop breast cancer. Self-breast examination have to be done by all women. Modifiable risk factors for breast cancer are risk factors for many other cancers and also for many other chronic diseases. So modifiable risk factors have to be modified every time, not only for arresting the development of breast cancer, but also for preventing many other cancers and other chronic diseases. So all of us may stop talking alone, only talking, but start practicing also. Each and every one of us should talk about this, and also we should start practicing this also. Thank you.
So, thank you. Yeah. Thank you.
Open for discussion.
Thank you, Dr. Kalavati ma'am. That was a wonderful presentation. Now we have a panel discussion which will be led by Dr. Jay Krishnan from your own department, the community oncology. And we've got panelists, radiologist who is specialized in breast imaging, Dr. Tina Sleeba from Rajagiri Hospital, Cochin. And our state president, who is also a radiologist, Dr. Gomadi Subramania, also specializes in breast imaging. And we have got Dr. Bipin Gopal, the nodal officer for non-communicable diseases for the state health services, who gave a fantastic presentation yesterday on the Shaili app and all, which can help us, which is already creating a lot of database on the high-risk groups on which further examinations are required. Over to you, Jay Krishna.
Thank you, Dr. Joe. Once again, that was a fantastic presentation by Dr. Kalaudi, and appreciate the fact that you have done a lot of work to make it a very very experienced panelists with us, and ma'am, I know that
is there any
in the
problem
recent
with the
years, we have seen
audio?
Jason, there is some audio issue on your side, maybe a connectivity issue. It is.
Can you hear me in between?
Yeah, we can hear you now. Please go ahead.
So we are seeing a rise in the breast cancer incidence in the last few years. So unlike in the 80s or 90s, when cervical cancer was a major issue, now we are seeing an increase in breast cancer. What could be the reason for this? Is it because of awareness, which is it because there is a change in lifestyle in the last 5 to 10 years or so, or is it because of increased awareness among doctors, or because of screening? Could you comment on that, madam?
Unmute.
Sorry. Maybe the rise in breast cancer which we see now may be related to all these factors. But I would like to say, at least from our Kerala experience, it is it will be much more related to our own lifestyle factors, because we all know that our fertility has reduced to 2 or 1, and our lifestyle it has also changed quite a lot. We have our dietary habits that also has changed quite a lot, and even there are many factors. So I think the increase in breast cancer rate which we now experience in Kerala and also globally may be related to our own lifestyle factors than any other factors.
Okay, because why I ask this question is that it's now emerging as a global problem. Even if you go to the developed country statistics, you can see increase in breast cancer incidence and all. It's a leading cancer among globally. So we all know that we have a standard treatment protocol for breast cancer treatment, but because of our efforts to reach to the doorstep of the rural community, and because of our effort to go for cancer screening, we are also finding a lot of people with some symptoms. So how often? Is there a protocol for follow-up among non-breast cancer cases, like with certain lumps or any other signs? Is there any defined protocol? How do you often follow up a patient with a breast lump which is not cancerous? Simply put it like that.
Yeah, I have gone through many studies. Each study they say different opinions about follow-up of benign breast cancers, benign breast lesions. In our institute, what we do is women with breast lumps, maybe we will give them 6 months for a follow-up, and after 2-3 follow-ups, if there is not much of increase in size, or if the lump is decreasing in size, we will give them 1 year follow-up. And but all these depend on their background risk factor. If they come from if they have a high risk factor profile, then we would like to keep them under follow-up, 6 monthly follow-up actually.
Okay.
With ultrasound screening, palpation, etc.
So we also have with us Gomadi ma'am. Good evening, ma'am. I forgot to wish you while I was introducing our speaker. So would like to hear more from you. Is it like in the US or in UK, they have specific guidelines for screening, like when to start mammography and all. So have you come across any sort of guidelines in India about mammography of utilizing mammogram for screening of breast cancer, like from which age group they have to start screening, or something like whether there's a risk stratification for screening based on mammogram, something like that. Could you comment on that, ma'am?
I think Tina can take that question, Dr. Gamadi.
Yes, yes. Yeah, Dr. Tina, please.
I think we follow the protocol that is accepted by BISI, that is Breast Imaging Society of India. And I think that's part of IRIA also, where we believe every woman is at an average risk in India. And we start screening, we recommend screening to start at the age of 40 and with mammograms and annual mammograms to continue. That is our recommendation. This is the recommendation of the apical, the BISI, that's the Breast Imaging Society of India. That's what they recommend on their website. And this is what we follow. So every woman, average risk once a year. And for the high risk, again, we follow the protocol as it is in the West, where we couple mammogram with MRI breast 6 monthly, meaning every 6 months a woman is under coverage of some imaging modality, either mammogram or MR. I mean, every 6 months is covered.
Thank you. Yeah, that's a good answer. So I would like to know till what age you will do mammogram. Is it like from the 40s to, is there any age group specific?
They say 70, 75, but then we see many women, I mean, many of the breast cancers that we do a biopsy and operate are on women who are beyond that, and they are in good health. And there are many patients who come at that age even for a screening mammogram. So I feel actually as a woman grows older, the chances of her getting breast cancer is definitely, I mean, that's how the risk factor goes. As we age, the chances are more. And if they are in good health and they are active, there's definitely no reason why we should be denying them screening.
Okay, yeah.
Jay Krishnan, let me add on to what Tina said.
Yes.
So when you look for a uniform policy for all over India, we need to consider these stages of epidemiological transition in with respect to the different states in India. If you look at that, yesterday we discussed the same point. The non-communicable diseases are already on the rise in south and west of India, but still the diseases of pestilence, famine, and most of the communicable diseases are the major causes of death in northern parts of India. So it is high time for us to look into the parameters or the guidelines that are being followed by the West, which has already achieved some kind of a developed state status. So there is enough justification, especially for a high-risk group, to have a screening with imaging modalities like X-ray mammography, or nowadays I combine this thing with X-ray and ultrasound, and wherever necessary MRI also has to be utilized. So I think we need to consider Kerala or some places which has got which are in a second or third stages of the epidemiological transition, and has to design policies accordingly, rather than like looking at all in the pan-India policy, which may be really adding on to the cost burden, because there the incidence may not be really high, especially if you take a state like Uttar Pradesh. 20 crore people are there, but their incidence of non-communicable diseases as well as cancers may be less, but the cause of deaths or mortality may be much higher due to infant mortality, maternal mortality, and all those stuff. So we need to have this perspective of epidemiological transition at the stages at which different states are. That also has to be considered before we come in for a pan-India guideline.
True. So in continuation to Dr. Rijo's comment, Dr. Bipin, I would like to ask you something. Like, for example, as you said in your yesterday's presentation, that like a district cancer control program, where we are using the Shiley app, and risk stratification methods are going on. And in the next phase, we are going to see a lot of screen positive cases coming to the primary health centers or family health centers and CHCs and THCs. So my take on is that, are these facilities adequate enough to tackle or to take care of the burden of those people who are coming with those risk factors? And can we can we use, or can we optimize our resources for screening detection? Because we'll be getting a lot of screen positive cases. Then we have to do we have to go for a diagnostic evaluation. So whether apart from the government settings, do we require additional modalities to take care of the management of pre-cancers or other follow-up? Your opinion?
Definitely, we will need additional help, actually from different corners, from different works of life. Because in my presentation yesterday, I told that there is a inequity in the distribution of healthcare facilities, especially for treating cancer. So the situation in Trivandrum may be much different from the situation in Palakkad or in Idiki, where the facilities for treatment management is very deep. So in such places, we'll have to have find new relationships, or new kind of relationship with the private sector or with the NGO sector, so that whoever we are finding as a screened positive case doesn't miss a chance of the actual diagnosis. So such a strategy should be developed in areas where the government facility is actually in a limited phase.
Jay Krishnan, can I add a point to that?
Yes, please.
Yeah. See, one thing that I think, especially when the cancer control programs by the state government and are being formulated and being implemented, an element that I've always noticed is, especially when we see patients with stage 3 or stage 4 breast malignancy, it is not that they have not seen a doctor. They might have seen a general physician, they might have seen a physician, they might have seen a gynecologist, but unfortunately, a proper workup has not been advised from different levels of healthcare. I'm not here for a blame game or anything. It is just the lack of a cancer focused or a non-communicable disease focused awareness and screening screening program that is lacking. And finally, these people end up at stage 3 and stage 4. And many of them, you ask them, they might have seen a doctor, a GP, for some other reasons, and for vague complaints, they might not have examined them properly. So all these things are happening. So one major lacuna from the medical community, I feel, is to enhance the opportunistic screening possibilities that all of us have, including the general physicians, the radiologists. That is why the preventive radiology, the branch itself, is opening up because of that. We do a lot of patients, we get a lot of data, but in that data itself, in our CT, ultrasound, MR, there may be early imaging biomarkers for cancers or some of the non-communicable diseases, which at this point of time, we are not even looking into that, because we are doing these studies as part of a diagnostic workup. We don't have a thought process to look at the early imaging biomarkers. We may be seeing it, but we don't report it. But if we start focusing on that, we may be able to give much more relevant clues for further risk stratification and follow-up for those patients. So that is one element that is thoroughly missing in Kerala. I think it is something that the state government also has to, because especially when they meet a gynecologist, make it a practice to have a screening for all these things, including a breast examination or a thyroid examination, whatever it is. So make it a mandatory thing. It's not just because most of the patients, female patients, have at least once or twice told to their gynecologist about some complaint in the breast, but it has not been properly advised to investigate with mammography, FNAC, and so forth. So this is one area I think state health department also has to consider.
Yeah, I think that's a very valid point, because we know that we need to find out more diagnostic investigation modalities also for these things, and we have to incorporate other sectors also to control the burden of cancers, especially breast cancer or even other common cancers. So adding to that, I just would like to ask Dr. Avni that
Avni has got some connection issues. He just
okay, no, it's okay. So Dr.
Dr.
Tina,
Jayakishan, I would just like to just add on to what Sir was just saying, Dr.
yes,
Rijo, regarding how women have actually gone forward and told their gynecologists, that or other doctors for that matter, that they could feel something different in their breast. I mean, the two prime areas where I feel we as a fraternity let down women with breast lesions or breast cancers is one where we still continue to rely on the power of fingers. I am someone who actually palpates a woman's breast, whether she's come to me for a diagnostic scan or for a screening, before I keep my probe on her. That's my way of learning how lesions feel. And frankly, I'm actually over the years really stumped by the fact that at times the breast absolutely feels normal, or at maybe just slightly nodular, or what most people call like fibroadenosis or fibrocystic changes is what is maximum that is felt. But as soon as I keep my probe, I see a malignancy. So not all breast cancers, are presenting themselves like what they used to be taught in books, like they present with a lump, they present with pudy orange. Not all women come to us in that stage. Many aggressive tumors like HER2 positive, they have very infiltrative nature, creeping right through the breast, and absolutely no much change in the breast. In fact, oncologists over the years, after seeing our reporting and the kind of malignancies that are presenting, they actually they've lost confidence in their palpation skills. The surgeon, for that matter, same thing with nodes, axillary nodes. They no longer feel, yes, there are nodes which are big, they can feel, but smaller nodes, we might have a whole lot of metastatic subcentimetric lymph nodes in the axilla, and clinically the node might be negative. So that's one place I think we should not be very confident in saying. In fact, just 2 days back, I had a patient who was who had a lesion in the breast. She had been feeling for 2 years prior to corona. She showed herself to a senior surgeon who said, don't bother about these things, and in fact scolded the patient. So 2.5 years later, the tumor is doubled in size. Most probably it was a hormonal lesion, so that's why it's actually doubled without possibly being metastatic right now. And she was just not able to get over the fact that she presented to someone 2.5 years back, and then someone just shooed it away. So that was most devastating, apart from the fact that and they didn't want to lose a single more day after the biopsy was taken. Every day they would keep calling me, has the biopsy come? Because they just wanted to start treatment stat. So that's one area I feel we are letting our patients down. Second area where I feel is general surgeons go in, and because any woman who is told she has a breast lesion, the next thing she wants to do is she wants to get it out. So most surgeons, I mean, I wouldn't say all surgeons, but women unfortunately present themselves to surgeon who would just say like, okay, I'll take this out for you. And many a times it turns out to be malignancy post-excision. So what happens is we have a lot of patients who have half tumors left within the breast. They have a big scar, the axilla is not addressed, lymph node sampling has not happened. In fact, we've seen metastatic disease. This is what I had presented 2 days back. I just wanted residents to understand that if you're suspecting a breast malignancy in a woman, the first thing is sampling, and then only you go through that, the stages of whether she needs surgery in the first place. She could be metastatic to start with, or whether she needs chemo in the first place, decrease the load of burden, burden of the disease, and then go on for surgery. So I think these are two very vital areas where we are letting our patients down, unnecessarily operating without having a pre-op diagnosis, and secondly, of course, relying too much on the power of our fingers.
totally agree with you, Dr. Tina. See, actually, as you have rightly pointed out, there are, patients who are, who will go to a hospital and they will get their excision done, and without without taking that margins and all. And even at RCC also, we are seeing a lot of patients like that. I think Dr. Kalavi will be knowing more about it. Ma'am, would you like to comment more on it? Because since you have been seeing a lot of cases, and what is your thought on it?
Yeah. Many women, they present to some local primary health center doctor or a private doctor running a clinic for the first time. And many times they don't, I would say, I would like to put it like that. That is, the doctors don't get an opportunity to examine the breast of the woman first, many times, because of many reasons. They will write some Evion or other some pain medication, etc., and ask them to come back after 3 months. That story is there. In some cases, what happened to one of the patients who came to me for the last week is, she was seen in our own General Hospital, Trivandrum, in the month of June. And the mammogram done in one of the private laboratory scan center specifically has written malignancy to be ruled out. The doctor has seen that report, but still he sent the patient for FNAC. FNAC report came as negative, but the doctor should have referred the patient to some other higher center then and there itself. But maybe the FNAC report is negative. He subjected for, she was here, the doctor was waiting for another biopsy. But by that time, 6 months, that is, she reported in the month of not June, April. And April, May, June, July, August, September, it was October, that October 3rd or something like that. So almost 6 months have gone. This happened in GH Trivandrum. Maybe Dr. Bivin may be, he may not be agreeing with me, but this has happened. Because, so these things are happening. Why, we don't know. And in the case of surgery, many surgeons are in the doing lumpectomy for the patient in periphery. And as was rightly pointed out by the doctor, tumor may
Unmute, madam. Unmute.
Tissue might have been removed. This is happening. So, but the thing is, every woman cannot be subjected for a imageological investigation. Of course, sometimes you may be able to do having 2,500 rupees doing a mammogram. So that is the issue. We have to depend on our fingers only. What to do? What is the solution?
So I think, yeah, it's like a combined approach. You know, we need this triple test, and we have anyway. I mean, we all agree that breast cancer it's a mystery disease. So we really don't know how to tackle it in a very comprehensive manner, and we are actually trying to get as much as information from the West, and based on all research studies, we are going forward. So, but I think when we talk about individual cases and screening, there's a slight difference. Like when we talk about screening as such, we are doing it among asymptomatic population. And when we talk about the diagnostic evaluation part, like Dr. Tina had rightly pointed out, you know, we have to be more aware of of those things, and we have to take a detailed case history. And even there's a chance of missing those cases, even they are clinically negative. That's a very good point. But when we talk about screening as such, and I think again, I mean, we have to do those stratification process, and then we have to look into that way. Anyway, I mean, we don't have a
Jay Krishnan, we have two questions from the audience.
Yeah.
So Mr. Praveen Nirmal has asked, when we talk about screening and risk, we usually talk about high-risk groups or characteristics that are usually personal or individual. Are there specific high-risk regions or geographical limits as well, or possible interaction with environmental, external or internal aspects? Is there any information on such regions, if any, in Kerala or India?
Yeah.
When we talk about screening and risk, we usually talk about high risk groups or characteristics that are usually personal or individual.
Yeah.
Are there
Yeah.
specific high risk regions or geographical limits as well, or possible interaction with environmental, external and internal aspects? Is there any information on such regions, if any, in Kerala or India? And the second question
Yeah.
is asked is it time to develop a specialist breast subspecialist cadre rather than club it under the broader category of gynec, like a hepatologist for liver conditions, hematologist, etc.? So these two questions are open for the panelists.
So regarding the first one, when we had the screening or when we had the risk stratification for the entire state, at least in 140 panchayats across the state, what we found was that the risk is almost same everywhere. There is no specified area in Kerala where we can say some kind of cancer is quite high. Maybe somewhere lung cancer or respiratory diseases may be high in Kollam or in the industrial areas, but not regarding the breast cancer. So that is for sure that there is no specialized or localized areas where breast cancer incidence is very high. That's our experience from the screening.
Yeah, even that is true, because even at in Kollam district, in that Karunagapalli belt, there was talk about whether there's an increase in leukemia because of the natural background radiation. And RCC was doing a study in collaboration with the Japanese research center, and for the last so many years, and they haven't found any specific high incidence of leukemia, but rather, I mean, they have got high incidence of lung cancer because of smoking. And it's almost the same like in Thiruvananthapuram or in other areas. So I think, as you have rightly pointed out, Dr. Vipin, that we as of now, we don't have any clue on any such high risk areas where you can see cases, but we need to do further studies and found out, and now we have to find it out. And coming to the second question, is it time to develop a specialist specialist cadre? Yeah, Dr. Bipin, any take on that, or can pass on to Dr. Kalavati? Dr.
I think Kalavati madam can answer that.
Yeah, ma'am.
I didn't get the question clearly. Is it time for
so ma'am,
getting
right now, a female with a suspected breast lump or a suspicion on breast cancer may be either approaching right from a general practitioner to a physician to a surgeon to a gynecologist. So there is no specific. So isn't it time to have a breast specialist to especially to tackle any problem related to breast, like a hepatologist for liver diseases?
I don't think even in developed countries they have such a cadre. We are, Dr. Bipin, etc. We are trying to enable our doctors sitting in the periphery and even our staff nurses in the periphery to be breast cancer specialists or breast cancer early detection specialists. That's it. And I don't think
when you look into the training part, I think many doctors are not being trained on cancer, early cancer detection. I think we need to conduct more training programs, sustainable training, retrainings, so that people will be aware about all these things, and opportunistic screening will automatically come in those gynec departments also, because those people coming with ovarian cancer, they can also check on for breast cancer. Like that, I think more training programs, especially for GPs, has to be conducted in a very sustainable manner. Dr. Bipin, I just have looked upon that National Family Health Survey Round 5. And in the recent survey, what they have written is that they have added two components, like screening of cancers for male and screening of cancers for female. I mean, for female cancers all over India, the total screening was hardly 2.9%, 2.6% for breast cancer. 2.6% for cervical cancer, 1 point something for breast cancer, and some 0.6 for oral cancer. I think almost the same prevalence, almost the same proportion of screening was conducted in Kerala as well. So in spite of we are being a 100% literate state, why there is not such a difference? And in the number of screen cases, because still we have a very low compliance to screen. What's
it
your
is actually
Shall
not a complaints to screening. Actually, a lot of screening programs are going on, but the data which is collected by the NFHS3 is from the national or the portal which actually sends the data from here to the central. And in that, the data from the NCD clinics is going. So the actual screening is happening in the camps. Actual screening is happening in the hospitals. In the NCD clinics, the chance of having a breast cancer screening or a cervical cancer screening is very less. So only that data is reflected in the Government of India registry. That's the reason why it is very low in Kerala.
Yeah, because it's
But if we add the other scams and all, it is much higher than the other states.
Yeah, ma'am, you are going to tell something? Kalavati ma'am.
No, I was telling, no, nothing. Okay.
Okay.
Bipin sir, I just have a suggestion. We got the Shaili app and the Asha workers is collecting data from the urban and rural areas. Suppose if we can have an additional data collection from those patients who are already reaching the GPs or the physicians or the doctors too, will it be helpful for us to further enhance the screening protocols, especially for cancers?
Definitely, yes. And we are actually planning to have the data of to compile the results of those patients who are referred by the ASHA worker to the PHC or to the other hospital, and those patients who are tested positive for the cancers and other diseases. So such a data is also evolving, and possibly by November 1st, we'll be able to release the first data on that. And the ministry is actually planning to reveal that data on November 1st on Kerala Preventive.
Okay. It's in the pipeline.
It's in the pipeline.
Okay.
Yeah, ma'am.
Shall I leave now?
Yeah, I
Okay.
think we'll conclude the session.
Yeah.
Any more questions, Jay Krishnan?
No. One question for Kalavati madam before we leave, ma'am. See, if you look, we always compare the breast cancer with the cervical cancer. So even though the incidence of breast cancer, the prevalence of breast cancer is getting high, the case fatality rate is much lower than that of the cervical cancer. Is it because of the imaging technologies that have come up, or the treatment procedures that we have availability, or is it the screening part which we are concentrating on, which is the main reason for that low case fatality rate?
Low case fatality rate in breast cancer. And are you comparing with
cervical
case fatality rate of cervical cancer and breast cancer?
Yeah.
Maybe because incidence of breast cancer is much less. Cervical cancer is much less compared to breast cancer. Breast cancer is 55 per 1 lakh, whereas cervical cancer is nearly 7 to 8 per 1 lakh. What happens is many cases of cervical cancers which are getting reported is at a very late stage. Even though the number are less, they are reporting at a late stage. That might be the reason why case fatality rate appears to be high for cervical cancer. In the case of breast cancer, we know day by day treatment modalities are increasing and patient complaints is increasing, and many patients are taking full treatment. So that might be the reason. But in the case of cervical cancer, I think this is a situation.
In that case, is it a high time to declare that mammography or the diagnostic test are the rights of a woman in Kerala also, like what Dr. Tina madam has told, the situation in the US?
That can be done. Is it practical? Is it feasible to give that right to every woman? Today, I have seen a Kudumbashri meeting conducted by Kudumbashri activists for the Thoyilorappu women who are doing their Thoyilorappu work. So that was very I was very happy seeing that that picture, because that girl was talking about breast cancer to them. How can we say that each and every woman standing there will get a slot for mammogram, free mammogram? I don't know.
Yeah, I think mammogram, I mean, I was about to ask Dr. Tina that in RCC, we are finding it difficult to give, dates for mammogram, because maybe it will take a month or so. So what is the, what is happening in private sector hospitals where you also have mammography units and all? I'm just asking as a general question. So because we have this problem of booking issues and all. So is it the same in private hospitals, or do you find it easier to get a booking in private hospital for mammogram?
It's definitely not easy. The numbers are increasing by the day. And added to the fact that we really don't have many people, even as radiologists, wanting to do breast imaging as a subspecialty. So not many radiologists are confident. Breast is something that's, it's a patch of cloud on an X-ray film. So anything there could be a tumor. So the fact that even tumors can be missed unless and until you are really trained and you're seeing it on a regular basis, that's something that prevents radiologists from doing it. So yes, we need more manpower, and I think that's the only way. Manpower, as in we need more hands from radiology looking into this. We possibly could train other non-radiologists or other clinicians, or I don't know, maybe that's something that we need to look in, where we can train. In fact, when I had gone for a short training in Singapore, where the mammograms are read by the radiologists, but the technician, it is a radiographer who takes precise ultrasound images at every clock position. Every centimeter distance from the nipple is measured and taken in 2 different angles. And I found it very difficult to digest that, you would rely on someone else to do that for you and then finally release a report as if it was your own. But that is a level of confidence they have in their people who they have trained to that extent. So I think we really need to look more into those possibilities also, because this is just increasing by the day. We have seen so many early breast cancers in patients who come for this health checkups. And what I have personally felt most difficult to convey is absolutely asymptomatic women. People in Kerala especially, I don't know how, in Chennai also it was a little more acceptable, but in Kerala, people find it very skeptical when you tell them that you have a finding in the breast which can be malignant. They actually take off for a second opinion, then eventually they come back because at times it is difficult to sample these lesions. So we need manpower to help us with, carrying out reading mammograms, help us with screening ultrasounds, help us speak with, there was a question sometime back where someone from the audience had asked, what specialty? I think I do a lot of clinical breast radiology. I think many people who practice breast radiology have to spend time speaking with the patient. You are the first one who is going to break that news to a patient. Unless you convince a woman, especially if she walks in for a screening mammogram, and I know the amount of effort it goes in taking to tell a patient that I'm seeing a focus of calcification, which needs a stereotactic biopsy. Absolutely time-consuming process. But if you just give them a report saying that, there are microcals which need vacuum-assisted biopsy or biopsy for that matter, they're not going to make any sense of that. So I think it is mandated that we take time, sit down and explain that finding to a woman so that she understands that, you really can't do away with this report. You have to do something about that finding and make them understand that we could possibly be dealing with malignancy. So all that is time consuming. So more hands on, deck, more trained people, radiologists, allied services, everyone needs to be on board for, for the unprecedented numbers that we are seeing in breast cancer.
Yeah, I think the numbers are definitely on the rise. That is why I said we are in an epidemiological transition as in any other developed nation, especially if you look at Kerala. We definitely, it is time for to have some kind of a mandatory screening this thing, especially for breast. This thing. But definitely, we do not have enough mammography, X-ray mammography installation as in the West. And that is definitely a lacuna. And as again, as Tina rightly said, imaging specialists who are focused on this thing, especially for the workup. Maybe you can get it done with the help of technologies, but workup, especially the clinical breast imaging specialist workup, you need to talk to the patient, convince them, and all these things requires more manpower. But I think our epidemiological stage is really taking us to that trend. If you still depend only on self breast examination and clinician breast examination, we may not be in a position to downstage the detection of breast cancer.
Actually,
That is what our
if you look into the Thiruvananthapuram population-based cancer rates from 2 to 3 years, I think most of the cases are now coming in stage 2 and stage 3. Unlike for cervical cancers, where it is coming in the more advanced stages, and even for oral cancer, even though it's a detectable case. So I think there is a slight stage shift as far as breast cancer is concerned, because if it is coming under 2 or 3, I think that survival has also increased because of that, and we can also enhance the quality of life.
Jayakishan, that stats also come to only 30% in Kerala. The stage 1 and 2, only 30%. But that is much better than cervical and all those things.
Yeah. So we are talking about an issue from Kerala. Even if we are not able to tackle this issue, like we are talking about a lack of trained manpower and even infrastructure and all. So unless and until we are able to sort out these issues, I mean, we cannot give a model to other states. I mean, just to copy what are our success in this cancer control and cancer control and cure. So I think anything to add from anybody?
I think we have to have some out of the box thinking, and how can our population afford it? Because I feel a lot of the institution, lot of the equipments, lot of the manpower in the private institutions that are relatively not having much of the workload. Though some institutions have, but many institutions in Kerala may not be having that kind of a workload. So integrating the private sector facilities and making them affordable also with some kind of uniform rating for a screening program that is being supported by the government or the cancer control program. So we have to think bring out some out of the box ideas to make this mammography screening as a mandatory for the high risk group, especially the women in the 40 to 60 or 60 age group, 70 age group, and utilize all the levels of healthcare, all the entities in healthcare, and that is the way out of it. And then a constant training, and the Shaili app is going to give us a lot of information on the initial database, but that can be accelerated and enhanced with the help of added screening program, added data collecting from the general practitioners, the doctors at the primary and secondary level, because patient is already there and they're willing to share their data to them. And it gives us a fantastic opportunity to create the cancer literacy, and also an early detection screening early detection campaign is also possible at that point of time. That is my take on it. Jay Krishnan, you can conclude if the session is over.
I think we had a very lively discussion regarding breast cancer. I think this for the first time, I think we are interacting, within a wider spectrum, because we have been talking mostly to public health persons or GPs, but we have with us now specialists, radiologists who are using these facilities for cancer detection and for treatment part. I think a lot of ideas have emerged now, and sure, definitely we need to have a consensus on how to move forward in it. And of course, breast cancer is increasing, like in other parts of the world. In Kerala also, we are seeing a lot of increase in breast cancer. But because of our coherent effort, both from the government side and from the private side, I think definitely we can move forward and enhance the quality of life of breast cancer survivors, and even we can, what all our dream, like in the Kerala Cancer Control Strategy, by 2030, at least we can reduce the burden of cancers by 1/3. Not only breast cancer, other cancers. It will be a great thing to do. So I think once again, thank you very much for all the participants, the panelists, Kalavati ma'am, Hemendran sir, Gomadi ma'am, Dr. Avni, Soumya, for this wonderful evening. We had a very good discussion, and I think we will move forward with all these things, and we can also have a further discussion for these things in time to come. Okay. Thank you very much.
Thank you, Dr.
Thank you
Jayakrishan.
very much.
And we will be having these sessions on Thursdays and Fridays. On next, we will be coming out with cervical cancer and head and neck cancers on next Friday, 13th and 14th. And once again, I think many of most of the discussions we had are from the Trivandrum Onco Summit. I think it is time for the medical professionals and the state health department and all of us to give a message to the community that cancer is curable. It's not just preventable. If you detected early, it is in fact curable. That's kind of a positive message and a action plan that can positively modify the risk factors, and that can definitely delay the onset of cancers. And early detection is going to be a very important key in this whole process. So thanks once again for all on behalf of the National Coordinator of the Preventive Radiology Program. And we will meet again next week, Thursdays and Fridays, with much more important topics on cervical cancer and head and neck cancers. Thank you all.
Thank you.
Thank you.